TopMedTalk.
This edition of Desiree's Roundtable is presented by Monty Mythen with Desiree Chappell and their guest, Peden, Professor of Anesthesiology and Executive Director of the Centre for Health System Innovation, University of Southern California, University of Bath, and the Institute for Healthcare Improvement. It's a standalone piece which followed on from the recent EBPOM Highlight, Lessons on EPOCH in the UK. It was streamed live on TopMedTalk.com and features additional contributions from Professor Sol Aronson, tenured professor at Duke University, alongside comments and questions from conference delegates and online listeners. It's a Q&A session regarding the Enhanced Peri-Operative Care for High-Risk Patients trial, better known as the EPOCH trial. Thank you to you if you took part. Have a listen and enjoy.
Brilliant. Thank you, Carol. So, was that disappointing?
Of course it was disappointing. I mean, I lived my life on this project for, and I think, aside from my personal feelings about it, I think it was disappointing for the teams, because we had 90 teams around the country, and, there was a few, if you look at any kind of John Overit's work from Scandinavia, from the Karolinska on quality improvement, about a third of people will drop out, a third will kind of not do much, and a third will be really good. And we probably saw that, but probably more than that. We had a lot of very dedicated individuals and teams around the country, and so it would have been lovely to say to them, we've really made a difference here. And that's why I want to, play up the fact that a lot of people did improve a lot of complex processes, and we shouldn't lose that.
Because I remember when the result was announced in London at the EBPOM meeting, there was this gasp from the audience, because we were certain there was going to be a difference. We had such belief in the fact that these quality initiatives and endeavours are going to make a big difference. And I think we've had a chance to think about it long and hard now. We think there's a lot of reasons, and you articulate them extremely well here, why that might not have happened. As you say, in parallel, outcomes have got dramatically better.
So, I think that's ultimately, we're trying to make care better for patients is important. And I think taking the learning from this, one of the things, and I'm sure the same could be said in the US for different reasons, was that a lot of our teams faced complexity, organizational change, mergers, and they would get things going, and then the chief executive would leave, and the whole organisation would change. And trying to deliver quality improvement on that background is very, very hard.
So whether it's right or wrong, thinking about it hard afterwards, my takeaway was sort of, let's call it lighter touch quality improvement. In other words, if you don't put those things in place, if you don't put the time, if you don't invest the time, if you don't invest the change managers, the sort of light touch quality improvement, let's print some posters, let's print some T-shirts and have some meetings, is a waste of time and energy. It's like either do it properly or don't do it.
Yeah, I think that, and that's, there are more and more studies coming out showing that this is tough. Organisational change is tough, and in major industry they take it very seriously, and we're trying to do it on top of our day job. And so I think you do have to invest in it. I mean, things like if our teams had had somebody who was collecting the data for them, and the study we did subsequently, or I was part of, the Emergency Laparotomy Collaborative, which was more a traditional quality improvement approach, we actually gave their teams their data every month. Whereas in this study, not only were the teams starting to collect it, but we expected them to download it themselves each month. So I think anything you can do to facilitate the information getting to the frontline teams about how they are doing, so they can then work on the improvement rather than spending the time at the computer trying to download an Excel spreadsheet, is very important.
Because the NELA you referred to, which is the National Emergency Laparotomy Audit, which might actually be a national quality improvement tool, that data acquisition tool and data sharing tool is live.
It is now. But again, at the time, remember, this study started only 4 months after that went live. As I say, most teams were struggling to get the data in. They didn't really understand the tool, and I don't think now you can go in and you can see how your hospital is performing benchmarked across the whole of the UK. But that wasn't really available at the start of this project. It was for subsequent projects.
Right, I'm going to get Slido up in a second. I'm going to get the microphone out to Sol in the auditorium. If you do want to ask a question or make a comment, please do get your hand up. We'll get a microphone to you. One last thing as I depart the stage for a second and go and sort that out is if you could do it all over again, what would you do differently?
Well, I have to say that, a plug for Rupert Pierce was that we were trying to do a randomized controlled trial in quality improvement, and that's what we did, and he did it. And, the trial was delivered very impressively. But I do think that focusing on a smaller number of things, it was actually, I think it was the NIH that wanted us to deliver an evidence-based pathway, and that was part of the trial funding, that we had to do a review of the evidence and deliver that pathway. But I think now, as we did in the subsequent study, I would only try to go for 5 components that I thought were significant. And I would have a lot more. The problem with the step wedge aspect as well is that I think getting teams in the room together, which I admit is much easier in the UK than in the US, getting everybody working on the same things together in the room regularly, and in subsequent studies we did that every 3 months, was very effective. Whereas we couldn't really do that in this study by the nature of the study. So there are definitely some things I would do differently, but there's a challenge. For those of you in the room would say, I don't believe this, it's not a randomized control trial. Well, this was a randomized control trial, but it may not be able to deliver because of the problems in what you're trying to do. So there's a balance between using the right technique for the right thing you're trying to test.
Carol, brilliant presentation, and I would take away from what you presented a little bit different. There's some very laudable features of what you've done and what you presented, notwithstanding the need to pull through and the rigor that is necessary to pull through effectively and the challenges that go with that, to really truly test, if you will, the hypotheses that was introduced. The outcomes, nonetheless, were impressive when you compare them to where you began. And so I beg the question, are large-scale quality control trials therapeutic?
Well, I think probably drawing attention to the problem is therapeutic, and getting people to measure and put in metrics so they can start to understand how they would do something about it is therapeutic. So I think those, and I actually think learning... I don't know how many of you in the room have done sort of quality improvement, but I think when you start to adapt, get in your head the system thinking and the number of people that you have to interact with, it's not just about anesthesia, but it has to be about anesthesia, surgery, CRNAs, techs, everybody, then I think that's very therapeutic. And it's good for morale too. Everybody's happy. If quality improvement is going well, and I don't necessarily mean by the results, I mean by the fact that you've got a good team together, it's really energizing. Whenever
I speak to groups about starting enhanced recovery, I reference what you've done with the EPOCH trial, and that it's, what happened with the outcomes is not necessarily speaking to exactly what happens in real life when you're trying to implement it. And one of the things that people talk about is, the complexity of their pathways. Are there specific ones that stuck out? Well, interestingly, and I've just been talking to Liza Wicks, who's running the AHRQ, will be running the emergency surgery arm next year. I think the difference is that you have to think about why these patients do badly, and it's because they're presenting sick in acute physiological derangement, and you have to get in on that really quickly. But I think from enhanced recovery more generally, I think it's organisation specific. What are we good at, and what, if we worked at it and got better, would make a big difference? Because some of the things in an enhanced recovery pathway may not necessarily make a huge difference, but if you don't have very engaged, informed patients, and you think, right, that's something we could work on, that is likely to make a big difference. So start there, I would say. But sit down with everybody early on and get their opinion about what would work for you. You were talking about enabling your team and kind of empowering them, I guess. A lot of people feel engaged, especially if it's like a grassroots movement, because that happens a lot. Like you said, it's not just a project that anesthesia wants to do. A lot of the times it is that, though. So how do you think, and through your experience through EPOCH, trying to get everybody on board from getting that top-down support? I mean, how does that work? Well, I think, and I know I would speak to Sol on this, you have to get to the chief executive, the executive leadership, and say, this is the reason. You have to have different languages for your different audiences. This is the reason why we should be doing this. These patients, if they don't die, they have long stays in ICU, high complications, readmissions, whatever the metric is that talks to that group of people to get them engaged and get that support and help provide some funding and some time for the other people. So I think it's finding the message
for each different audience and bringing them all together.
I would just add that you made the point there's a difference in culture today between the motivation that we would have to encounter in the States compared to the UK. And I think it does speak to the motivation even within the zip codes within the US to have that sort of burning platform, if you will, to embark on this.
Well, the next move in the UK on this is that hospitals will have to have it's called a best practice tariff, so you have to be seen to be following a pathway, or you will have money withheld. So there is going to be some financial incentive attached.
Getting a little bit into the nitty-gritty here, how much of a signal did you have about time to OR for these patients? Because the biggest barrier I see as an anesthesiologist is, we can't take this patient to the OR, they need an echo, they need their pacemaker interrogated, they need blood cross-matched, whatever it is. And in the area of emergency surgery, the increasing signal, certainly from the trauma community where I live, is speed wins.
Yeah.
And that the getting to the OR, getting source control of the problem outweighs almost all of the comorbidities and their potential for harm.
What we were trying to get at with this group was those patients that get lost in the system. They're seen and they've got a bit of obstruction on a Friday, and then maybe, their attending doesn't see them again for a couple of days, and they're seen by them. And what we wanted to put that sense of urgency in. And what we found was, even if the surgeon wasn't saying we need to operate now, these patients were being seen more frequently with a much more sort of when do we need to go, proactive approach to that. So I think that was helpful. And actually, in the next study, the emergency collaborative study, we saw even faster time to theatre. So people were really getting this in their head that once the surgeon made the decision that this patient is septic or whatever, we have to get on with it. They can't wait till the next day or the next list.
So I'm going to go to some of the Slido questions. We'll take the first question here if we may. And although it says perioperative medicine and ERAS, it's really a question about external experts to jumpstart programs in the general sense compared to internal.
That's a really good question. I think, and in fact, I tweeted about it once, and it's my most popular tweet, that it's much easier to go in and be an expert from outside than change things in your own organisation. And that came from, I did a lot of work in Denmark and Scandinavia with IHI, and, you sort of get the red carpet rolled out, and you go home and try to do the same thing in your own ICU, and everybody walks away. So I think it's very helpful if you can get somebody in that whichever tribe, or maybe all the tribes in the organisation, respects and believes in, to say, this is a really good thing, we should get started on this. It's very helpful. Because if you're the frontline person there, even if you're a world expert, you're still, Carol or Mike or whoever. I think it does help. I wouldn't say it's essential, but it is going to make life easier.
And I would add thick skin as a virtue.
Yes. And patience, resilience.
Maybe we should have an exchange program for experts. And
There's no doubt about that somebody coming in from outside. I think our experience with the National Enhanced Recovery Program is they gave us relatively little resource. They did give us access to the data so that you could have honest conversations with people, because everyone's length of stay is 4 days and no one has any readmission rates. And you say, well, that's interesting because I've got your data here. And the other thing they gave us was change management experts who really didn't care. They weren't trying to offend people, but they were really fantastic in saying you were supposed to send a 4-person team along to this quality improvement endeavour. Only 3 of you can come, so you can go now. They would send them out of the room. They would say, we need to regroup on this. We're taking this seriously. And it was
another tip we did with EPOCH that did work well is, again, when you come from outside as an expert from a national study and things, you can say, right, the first thing we're going to do, or for the first meeting, I want you to look at 5 case notes or 3 case notes and see if you're all experts on this, did you do this to this standard? And that's not a lot of work. And people will do that and come and talk about it when there's an external facilitator, which they may not do. And often what you find is people do think they're doing the right thing, but they're not always doing it reliably when they look at a very small sample. And that was a very helpful thing. But I think that was easier to ask people to do it coming from outside.
Another Slido question here. Was there any signal for degree of improvement for any hospitals, i.e. lower performing hospitals showed most improvement? This is my theory at school, is the sooner you fall behind, the longer you have to catch up.
Yeah, that's...
Is that...
Well, one of the problems with some of the metrics was that and this is again has to be interpreted for US audiences, that one of the metrics was the attending surgeon and anesthesiologist had to be present in the OR. Now, in the UK, you're in your training for 10 years. So you can be 35 and be still a trainee. So I'm not saying you've basically got, an intern doing your operation, but we focus very much that these are complex. If anybody should have the senior attending in the room, it should be these patients. And most places were already performing quite well on that. So it was a very hard metric to move. So I think, again, if you're going to pick things where there is room for improvement and you could improve. We are going to look at 3 high-performing, 3 low-performing sites. But again, I think it's going to come down to the context in which they were trying to work.
There's a question here, which I don't know if you're happy to take this one, Carol, because it relates to ERAS in the broadest sense. It says, does this perhaps show that long-term outcomes with ERAS are speculative, short-term, though, metrics such as return to work, resumption of activities of daily living might show benefit? Where do you stand on the ERAS? Do you think ERAS has played out to produce longer-term benefits? Or do you think that's still a known unknown?
That's a good question. I think we need more of those studies, but I'm an ERAS believer. The next study, the Emergency Laparotomy Collaborative, published in JAMA Surgery yesterday, showed a reduction in mortality down to 8%, but that was not a randomized controlled trial, so that was on the background of, everybody was improving, although we did get below the national norm. So we have got a study that shows, but that was a simpler study, just looking at 5 components of improvement. I personally think the central tenets of ERAS of getting patients and families involved in their care, understanding what they're going into, motivating them, getting fit prior to surgery is going to roll out into longer-term outcomes, but I think we need more data on that.
So we'll take the last one here before we move on to the next speaker. Just to remind people listening at home, if you do want to go on to slido.com, as you listen to the talks, if you put in the code EBPOM19 as shown on the slide here, then you can post your questions from not only in the room but also around the world. We'll pick up on the educational question related to EBPOM and EBPOM later on, but we'll leave you, Carol, with the last one before we get one from the floor, which is if you looked at different sets of hospitals, were some much better than others? Yeah,
there was definitely differences. And again, it went back to the people that were very well socially connected within their organisation, had strong teams to begin with. That did better. I mean, I think not surprising. And also people who were on a stable background where there wasn't a lot of organisational change. And we saw some stunning performances. I won't name hospitals, but I know Dr. Miller worked at one of them, and that was absolutely fantastic. They were really innovative. They got everybody involved, and they came up. My hospital in Bath, we came up with some great ideas that are now used nationally. So there was different levels, but everybody really tried.
That's that Tim Miller at the front there you were referring to.
Yeah.
Carol, kudos on a great...
Sorry, Tony, could you introduce yourself? I should have said that to people.
So, surgical bias. I could think of any number of intraoperative decisions that could really impact the outcome of a study this complex, given the difference in pathologies, difference in surgical decision-making. But you had the tyranny of numbers. Was there any way to tease out specific surgical decision, intraoperative differences between the high performers and low performers?
No, I don't think so. One of the things, again, was if you go back to some of the earlier studies that preceded this, and I know it's controversial, the goal-directed fluid therapy intraoperatively was, in the EPOCH study, was associated with improved outcome and what also was ICU admission postoperatively. So I think the perspective of the whole team treating this patient is very high risk. I think if you go back to some of the earlier NSCIP papers, spending an awful lot of time in the OR, very long surgery in these patients is an issue. But that didn't come out of this, but it's based on some of the NSCIP studies. So Nothing specific. There probably is more that could be drilled down, but we were trying to keep this at fairly high level as a whole pathway change.
The reason I bring it up, and it wasn't from a different idea, but we learned in rectal cancer, originally the Swedes did a study, found a very high local recurrence rate, invoked radiation therapy, and it dropped it by 50%, still to a number that most surgical teams would have considered unacceptable. What all of a sudden turned out at the very end of the discussion was there was a way to do a better operation up front, and the relative benefit of radiation really melted away over time. So I wonder here, something like, my bias, overuse of open abdomen could definitely impact outcome. Resection with diversion, there are any number of things that could alter that.
Well, and also the whole issue of the patients in whom this is pretty much futile. The patients who are at end of life, and that, all that Zara Cooper and all that group at Harvard looking a lot at that. We didn't overall in the UK see a massive drop in numbers of patients being operated on. So I don't think that is the main reason for success. But I think there will be patients now who people will risk score them and look at frailty and things like that, and perhaps have the conversation that this may be futile. So, but I agree, there's so many factors in this.
Right, just a huge round of applause, please, for Professor Carol Peden.
Nick Majerison here. Thank you for listening to TopMedTalk. Now, make sure you've subscribed to TopMedTalk on your podcatcher, or however it is that you're listening to us at the moment. And you're spoilt for choice. We're on pretty much every single podcast platform you could think of. So make sure you've subscribed. Make sure you've engaged with us on social media, Twitter, Facebook, LinkedIn, YouTube. And make sure you've signed up for our email updates on topmedtalk.com. If you get yourself there, you'll find a website that contains all of the podcasts that we've ever done, and it gives you the chance to sign up for our email updates. That way we can always get in touch with you and tell you what we're up to. Oh, and while you're online, check out ebpom.org/meetings. While you're there, get excited about EBPOM London 2019, the London Peri-Operative Medicine Congress. It's on July the 2nd, and it's one of many meetings that EBPOM organises around the world in order to communicate the perioperative medicine message. Have a look, ebpom.org/meetings.